Ahead on this edition of Being Well, it's a new guest on our program. Dr. Ryan Pine of Advanced Ophthalmology in Charleston will be here. We'll be talking about diabetic eye diseases such as retinopathy. Dr. Pine will explain the stages and the treatment. We'll also touch upon cataracts, glaucoma, and we'll find out if those things called floaters can be dangerous. That's all just ahead, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. AlphaCare, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. AlphaCare, compassionate professional home care. Additional funding by Jazzercise of Charleston. I'm here with Dr. Ryan Pine of Advanced Ophthalmology in Charleston. Dr. Pine, let's get started with our discussion and tell us a little bit about an ophthalmologist and what you do.
Okay. Ophthalmologists are medical doctors who are trained to treat diseases of the eye. We go to medical school to learn the whole body, and then after medical school we kind of branch off through residency to go into more specialized training of the eye, the visual pathway diseases that affect it, and ways to treat them.
Okay, so when you talk about diseases of the eye, what kinds of things do you see in your practice?
Most commonly cataracts, diabetes, diabetic eye disease, glaucoma, crossed eyes, macular degeneration, both wet and dry, other retinal diseases.
Okay, so do you actually, an optometrist, just to explain real briefly, what's the difference between an optometrist and an ophthalmologist? Because I think a lot of our viewers probably have that same question.
Sure. I get that question a lot. Optometrists are go through a 4-year school looking directly at just the eye with treating the refractive state of the eye, such as glasses and contact lenses. They're also trained to screen for diseases of the eye and have some limited treatment roles. We're lucky to have some good optometrists in our community here. So.
Okay, so we want to get back into some of the common ailments that you treat in your office, and one that seems to be that you see a lot of is you see a lot of our diabetics. And why is it important for diabetics to have their eyes checked?
Well, I think it's, as an ophthalmologist should be involved with every diabetic patient's care, because it's part of the full treatment care team, if you will. When we look in the back of the eyes, and if we see changes in the back of the eye that are from diabetes, it's important to know that those changes aren't limited to the eye. Those are going on elsewhere in the body. And as eye doctors, we get to actually see blood vessels where other doctors have to inject dye into the veins or so to see vessels. So we can not only help with the vision, but we can help with the other physicians knowing how well the management is going and treatments are going.
What kinds of things do you see when you look in the back of an eye of a diabetic?
Sometimes nothing. Sometimes things look good if there's really good control. Other times we can see early cataracts form. We can see changes in blood vessels that can lead to bleeding or swelling in the back of the eye. New blood vessels growing in the back of the eye, which we never want to see.
Why are diabetics more apt to have eye problems than non-diabetics?
Well, I think to understand that, you kind of have to understand a little bit about how diabetes affects the eye and how diabetes works in general. Diabetes is obviously a disease where the sugars in the bloodstream are high. As those sugars float through the bloodstream, they cause changes and they deposit into the walls of the blood vessels, which leads to hardening and narrowing of the blood vessels. A hard and narrow blood vessel doesn't carry as much blood, which doesn't carry as much oxygen. And the back of the eye, in particular, is a highly metabolic state. It needs a lot of oxygen. And so you start to see changes in the blood vessels when we dilate you and look in the back. These changes can be little out pockets of the blood vessels, or those little called microaneurysms. Those little microaneurysms can burst or bleed. They can leak fluid or blood or fats into the retina. In a severe state where the eye is kind of starved of so much oxygen, if you will, the eye will tend to grow new blood vessels to bring more oxygen, which sounds great, but those new blood vessels are very destructive.
Okay, and why? Yeah, why is that? Because that does sound like a good thing.
It does. The new blood vessels, they're not as good as the ones you're born with. They're very leaky, and they tend to close off and scar and pull on the retina and cause retinal detachments or large bleeds in the back.
So
of the
is this what we're talking about, diabetic retinopathy? Is that what we're really talking about?
It is, and it kind of goes through the stages. Early changes from diabetic retinopathy, maybe just a few little microaneurysms here and there, or a few little spots of bleeding. The more numerous those spots are and the location of those spots kind of quantify the stage of retinopathy that you have. In ophthalmology, we consider it nonproliferative or proliferative diabetic retinopathy. Nonproliferative just means there's no growth of blood vessels yet, and that's subdivided into like mild, moderate, and severe. With proliferative diabetic retinopathy, it's the more advanced stage where new blood vessels are growing and have a very high potential to cause vision loss or blindness.
So are there some sort of symptoms if someone's sitting at home? Like, can they actually tell through their vision that they have retinopathy?
Unfortunately, in the early stages, no. Most patients are unaware when I tell them there's some changes in the back of the eye. As if there are a little bit more advanced stages, they may notice some blurring of the vision, maybe blurring of the central vision. Sometimes that just comes from cataracts. Sometimes it comes from swelling or bleeding in the back of the eye.
So when you look at your diabetic patients, who typically is at greater risk for the more advanced retinopathy? What kind of diabetic?
Well, type 1 and type 2 are both equally at risk. The pregnant ladies who are diabetic have an increased risk of having either findings of retinopathy during their pregnancy, or should they have retinopathy prior to pregnancy, it can worsen. Essentially, it comes down to the longer you've had diabetes, the higher your risk of having findings are.
So I know that there is this connection between A1C level and retinopathy, but first talk about what A1C is.
Sure. Hemoglobin A1C is a blood draw or a blood test that your primary care doctor or who's managing your diabetes will check for you every 3 to 4 months. That lab test looks at changes in the red blood cells that are caused by high sugar levels surrounding them. We know that a normal hemoglobin A1C is around 6% or less. In diabetics, it's often a little bit higher. The reason it's important, in my opinion, and the reason patients I think should make it a goal of knowing what their A1C is and trying to keep that number low, is because that 3-month average of blood sugars, we have studied that in ophthalmology, wondering who's at risk for going blind. And what we found was patients whose hemoglobin A1C was less than 8% have a significant decreased risk of going blind. So it's not to say 7.9 is as good as 6.9, but I think a target of at least less than 8%, at least early on in diabetes, is a great goal.
So for someone who has diabetes, they want to be less than 8%, is that what you said? Or what's a level?
It is tailored in a little bit individually, and the primary care doctors and endocrinologists are very good at that. But in my opinion, less than 8% is a goal that everyone should have. Some doctors prefer their patients closer to the 5.5 to 6% range. Some think it's okay if they're in the upper 6s.
So what do you, as the ophthalmologist, when you get those A1C results, how do you use that information? Well,
I don't get the results sent to me. I usually ask the patient, and that's always a telltale sign of how involved in their care they are. Some have no idea what an A1C is. Some have no idea what the number is, and others know it very well. And so I typically try to explain to them about the hemoglobin A1C, and that a target of less than 8% is important for the vision, and explain why, as we just discussed.
If you have someone, let's talk about treatment. If someone does have diabetic retinopathy, how do you obviously determine the stage? Then how do you determine the course of treatment for them?
It can range very much accordingly to what we see in the back of the eye. Very early stages, we may just observe, because they're reversible in early stages. If the patient maybe increases their overall activity in their management or their management.
The things that they should be doing to manage their diabetes in the first place.
Help themselves out a little bit sometimes. The once the swelling of the back of the eye happens where it's limiting the vision, there are a couple different things that we can do. We can inject medicines into the back of the eye that will help get rid of the swelling. We can use certain lasers to the back of the eye to help prevent those blood vessels that are bleeding, to help them dry up. In the more severe advanced stages like proliferative diabetic retinopathy, we use lots of lasers and combinations of injections and sometimes even surgery.
Are most of those treatments things that are done in an ophthalmologist's office, or do you go to a hospital?
Most are done in the office. I mean, surgery is obviously done in the hospital, but most of the stuff that we're able to do, we're able to do in the exam chairs.
So if someone has some, maybe the lasers or the injections, are the results, do they take a couple weeks to take effect, or is it kind of an instant sort of thing?
It's definitely not instant.
Okay.
It's definitely not instant, but it does take oftentimes several weeks or months to get some improvement, but at the same time, the patients and the doctors are working together over those next few months, we make things a lot better. Okay.
If someone has the treatment, does that mean they can't get it again?
Unfortunately, no. The underlying disease is if it's under better control, oftentimes a few treatments may be all they need, but too often not. It's a battle. It's a frustrating disease for the patients and for the doctors, but working together, we can make things better.
Do people, if they have it, do they get it always in both eyes, or can it just happen in one? Is it?
It's usually in both eyes. Maybe the severity is slightly different between the two eyes, but if it's looking like it's just in one eye, then there's some other things that I would worry about rather than just diabetes.
Okay. If it's left untreated, what happens?
Patients lose a lot of vision, and most of the time it's extremely blurry vision that glasses or contacts won't correct, or cataract surgery wouldn't correct. In worst case scenario, patients can go completely blind by having an untreated proliferative disease, and it's fortunately we don't see that much nowadays because we have very good treatment options, we have very good medicines, and a very good diabetic care team, if you will.
Is there any, I want to talk a little bit about cataracts and glaucoma, because I know cataract is something you deal with. Are there other things that you wanted to address in terms of retinopathy? Because
well, it's along with diabetes, there is a kind of a diabetic eye disease label, which diabetic eye disease not only includes diabetic retinopathy, but it also includes cataracts and glaucoma. Patients who are diabetic have get cataracts at a much younger age, sometimes in the 30s, 40s, 50s. Patients who are diabetic have twice the risk of developing glaucoma. And we think that's due also to the blood flow compromise to the optic nerve, just like the blood flow changes in the retina. So it kind of makes sense.
So they're at risk for two other things.
Absolutely, absolutely. And that's part of the normal screening that we all do on every exam.
Okay, I was going to ask, when someone, a diabetic, sees their ophthalmologist, what sort of tests do you run?
Well, first of all, we have to know your vision, because that's why you're here to see us. No matter what I tell you, what you want to do is see better. So we have to know how well you're seeing. Then we will look at the front of the eye with our microscopes or our slit lamps, shine some bright lights at you, check your eye pressure, which is a part of the screening for glaucoma, and then dilate the eyes, which is the most important for a diabetic. Every diabetic patient should have at least one dilated eye exam per year, and then depending on the findings, we reserve the right to shorten that.
But from what I understand, a lot of those tests, compared to some other tests that we have, it's this fairly non-invasive.
Absolutely. Yeah, I'm sure it's not much fun to get a really bright light shine in your eye.
Or that puff of air. No one likes that.
Yeah, and we don't do that at our office, luckily. But it is a lot of bright lights, and me poking my fingers around on your eye for sure. So, but it's all very worth it in the end, because oftentimes I can find out a patient's diabetic before they ever knew, and so we can see changes in the back of the eye, and then start doing some of the investigations with the primary care doctors and actually determine patients are diabetic and save their eyesight.
Are diabetics shocked or surprised that they may lose their eyesight? We often, talk about diabetes on this show, and it's, losing of limbs and diabetic ulcers and things. Are they surprised about the loss of vision?
Well, I think probably not surprisingly, the one sense that most people tell me that they never want to lose is their eyesight. And so as soon as they hear that their eyesight can be affected or they can lose eyesight from this disease, oftentimes it gets them into the office. Mm-hmm. So I'm not so sure if it's surprised. Sometimes there's some denial, but it's not usually surprise.
So it sounds like if you have those early stages of retinopathy, keeping your diabetes under control
absolutely
is the way to.
And everybody talks about diet and exercise, mm-hmm. which are extremely important to do. That lowers your sugars without any medicines. Mm-hmm. Oftentimes patients who are diabetic also have high blood pressure and high cholesterol. You take diabetes, high blood pressure, and high cholesterol, and you add those things together, and that all equals damage to the blood vessels. Mm-hmm. And those damage to the blood vessels that happen to the back of the eye that are going on elsewhere in the body leads to early heart attacks, early strokes, not just vision loss. So it's mm-hmm. important all around.
It's kind of a cumulative effect.
It is. And
I want to spend these last 10 minutes talking about cataracts and glaucoma, because that's something a lot of people deal with, whether they're diabetic or not. Let's talk mm-hmm. about what is the difference between cataract and glaucoma.
Pretty significant difference. The cataracts develop inside the lens in the eye, the mm-hmm. human lens. It sits kind of behind the colored part of the eye, the iris. It's about the size and shape of a chocolate M&M. Mm-hmm. And so I describe it to my patients that chocolate used to be crystal clear, and over time those lens proteins start to get cloudy. Mm-hmm. Once it gets to a certain stage, we can kind of remove the candy shell of the M&M, take the chocolate out or the cataract out, and replace it with an implant, and gets patients seeing much better. In diabetic patients, those changes to the lens happen earlier. As the sugars go up and down in the bloodstream, the sugars cause changes within the lens that form the cataract faster.
Mm-hmm. Can everybody get cataracts over time? I mean, is that just a natural part of aging?
It is. I tell patients, if you live long enough, you get them, and if you live long enough, you'll need them taken out. I know a lot of people
have had the cataract surgery, so it seems like a fairly common thing.
It is. You can have a cataract as a newborn, mm-hmm. in the teenage years, and in late elderly patients, and so it can happen at any walk in life. And having a cataract doesn't always mean you're old. I know a lot of patients feel that way.
Can you do anything to prevent them?
Not necessarily.
Okay. Mm-hmm. Let's talk about glaucoma. That's mm-hmm. another one.
Glaucoma is a very broad subject that it essentially is oftentimes damage to the optic nerve, mm-hmm. which causes permanent vision loss. The optic nerve is an extension of the brain, and just like the spinal cord, if you injure it, sometimes it's hard to get that function back, and it's the same way with the optic nerve. Oftentimes in glaucoma, there's associated pressure in the eye that can be oftentimes high, not always, mm-hmm. but oftentimes high. And so sometimes just lowering the pressure in the eye with drops or surgery or lasers can keep stress off the optic nerve and keep damage from happening.
So when I think of like pressure in the eye, like it's pressing outwards, or what's creating the pressure? Is it fluid?
It is fluid.
Okay.
The eye has essentially two chambers. The front chamber is filled with a water called aqueous, and the back chamber is filled with a jelly called mm-hmm. vitreous. It's the front chamber that we think has the most pressure relation to guglaucoma, because that fluid inside the eye, which is different than tears, this is inside the eye, mm-hmm.
is
always made and turned over. So there's a faucet where the fluid comes from, and there's a drain where that comes mm-hmm. from. And sometimes it's just an imbalance in that situation that leads to an increased pressure.
Okay. And if you have been to the eye doctor over the years, some places still use it, that puff of air, mm-hmm. but you said there's different ways now of testing that.
Sure.
It's not an awful thing, but it's just anticipating.
I understand. I hear that a lot. That's not going to be a puff of air, they were saying. So no, there are multiple ways to check the intraocular pressure, but the gold standard is called applanation tonometry, where we, after applying some anesthetic to the eye so that you don't feel it, we actually lightly touch or indent the front mm-hmm. of the eye, and that's the gold standard to measure intraocular pressure.
You talked about, for cataracts, you get rid of the cloudiness. Mm-hmm. What is the treatment for glaucoma then?
The treatment for glaucoma ranges depending on, there are various types of glaucoma, and it depends on maybe what the cause of the glaucoma is. Sometimes a simple laser can prevent glaucoma. Other times you need eye drops to keep the pressure low. Our drops work by either turning the faucet down or opening up the drain. Then there's lasers that can help on the drain. In some advanced cases, you actually have to have surgeries to create additional pathways for fluid to come out of the eye. So.
I wanted to ask you, I looked this up this morning, what are floaters in the eye? I know a lot of people have probably seen that stuff floating in there.
The little gnat that you
swipe
at?
Yes, what is that?
Floaters come from the back of the eye, with, like I just mentioned, the two chambers, the water part in the front and the jelly in the back. The jelly in the back starts to kind of ball up and clump on itself as you add candles to your birthday cake. And so typically those little, when those little opacities get within that vitreous jelly, as light comes through there, it hits that little opacity and then it casts a shadow on your retina. And so you're seeing the shadow of that, kind of like the sun and the clouds and the earth. So.
Is it dangerous, or is it something we should be worried about?
Well, just a few floaters here and there are very common. What we worry about when we think of floaters is a whole rush of them, almost like a swarm of bees, or somebody shook up a snow globe. Oftentimes that bunch of floaters is associated with bright flashing lights like lightning, and then maybe a change in the peripheral vision. And those things we do worry about as causing some damage to the retina, such as a retinal tear or retinal detachment. And so I think anytime you have new floaters, it's always good to have your eyes checked. If you're having flashing lights, floaters, and a change in your vision, then it's more of an urgency.
I was just going to ask, what are some warning signs of severe eye issues? We know about the signs of stroke and heart attack and, act now. What are some eye things that you've mentioned a couple of them that we should really keep track of for either us or someone in our family?
Well, I think the flashing lights, floaters, and a change in peripheral vision, those three things together is pretty ominous sign. Other things, if something straight doesn't look straight, like there's a bend in a telephone pole that you know is not there, or the road curves, if you're all of a sudden your vision's okay, but then all of a sudden you're seeing two images of something, that can be alerting. So. All
right, I want to ask the ophthalmologist here, what are things that you do as an ophthalmologist to protect your own eyes? I've asked the dentist, what do you do to take care of your own teeth? What do you as an ophthalmologist do to take care of your own eyes that maybe we should be doing as well?
Well, I would say the first thing I do is try to eat healthy and exercise, because I think that not only helps the eyes, it helps the whole body. After that, wearing a hat and sunglasses are probably the most thing you can do at a younger age to protect you from. We think UV light and damage over time has a role in not only cataracts but macular degeneration and other things. And so I think wearing a hat and sunglasses and just trying to take good care of yourself in general will make a big difference.
So do you recommend, I know you said you have some small children, do you recommend for kids getting them wearing sunglasses when they're outside?
Yeah, and my boys love it. They won't go outside without them for some reason.
Well,
so.
They look cool
and
that
they
way.
see dad in them, I think. But yes, I think protecting the eyes, just like sunscreen, you go out, sunscreen for the skin and sunglasses for the eyes, I think is great.
All right. Is there anything else that you want to address that we haven't got to yet?
I don't think so. We touched on a lot of subjects.
We did. Well, we're going to have you back again, because there's so much information out there. And I think when our eyes are fine, which they are, most of us for the most part, it's not a problem. But boy, like you said, when you risk maybe losing your vision, it's a wake-up call.
Absolutely, absolutely. Well, that's what we're here for.
All right. Thank you so much for coming by Being Well today. We appreciate it.
Being Well is also available online at our YouTube channel, youtube.com/WEIUTV. Just look for the Being Well playlist. Here you can view current as well as past episodes.
Well, we're out of time for this edition of Being Well. Thanks so much for joining us, and we'll see you next week.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org.
Alpha Care, specializing in adult care services that range from those recovering from recent hospitalizations to someone attempting to remain independent while coping with a disability, chronic illness, or age-related infirmity. Alpha Care, compassionate professional home care. Additional funding by Jazzercise of Charleston.